Right. Thank you everyone for joining. Um, Sorry for the delay. I hope you can sort of make out my face from here. Um, yes, Francis Musinguzi is my name. I have met a couple of you, and I will be running this or facilitating this breakout session on interoperability. Um, I'm really excited to host this because it's it's something that really I've been dealing with the last few months, and Stephen on this call will know a little bit about my struggles with this. But just to get a few housekeeping bits out of the way, I hope to have this sort of a bit interactive, like a conversation, just a general conversation. But at the same time, if there is scope for us to have, either slides or uh, a, a, a chat, a 5-minute sort of chat, if you have, or a talk about something that is on your mind, any key ideas that you'd like to sort of present. So before I go further than that, also a bit of timekeeping. Our responses, try and keep them a bit short, as short as you can. And also, what we'll try and do is we will allow we will allow the participants, not the panelists, to basically present their questions in the chat or later on, about 15 minutes to the end of the process. Right, so that's that. So I'm going to share bios. I'm asking for forgiveness in advance because the panelists on this session are really, I want to say seriously accomplished, but they're very accomplished. So the bios would be sort of, pages long. So they might be a bit short. So if your bio is a bit short, please forgive me. I just had to get a few points into it. So let me share that now. Whoops. Okay. Right. Can you see my screen? Is always the first question.
Yep, we can.
Excellent. Right. So yeah, the main title of the session is Understanding the Building Blocks of Interoperability. And yeah, that's the general title, but we could sort of do what we like with it around the same scheme. Firstly, our first panelist is Stephen Senkomago Musoke. He currently works with METS in Uganda, which is an organization that whose main role at this point in time is to manage the architecture, design, and development of the Uganda and rollout of the the electronic medical record system for Uganda called Uganda EMR, built on OpenMRS. Stephen is passionate about growing the technology community in Uganda, and one thing he has said to me personally, and I've heard him speak about on multiple occasions, is that he is invested in others growing and succeeding in the ecosystem. So he's very invested in helping other organizations, other players in the market, in the sector, to do well, to use his past experience to encourage growth in the sector. Obviously, there's a lot of emphasis on at this point from his side on open source using OpenMRS, but he also leverages his entrepreneurial experiences to drive the adoption of technology to achieve business goals. So he's got lots of different fingers in different pies, if that makes sense, Stephen. I hope I've got that right, Stephen.
Yes, you have.
Excellent. So I am not sure whether Steve Wanye is on here. I'll just check quickly. He sent me a message that he might not be available, but he was meant to be one of the panelists. Steve works for Intellisoft. He's basically experienced in architecting, development, adaptation, implementation of OpenMRS. So I am certain that Steve and Stephen have actually worked together, especially on the OpenMRS side of things. He's a board member for the OpenMRS community of practice and has a lot of different roles, including, very importantly, is the founder of Intellisoft Consulting, which is a software development consultancy outfit. So he's not around, but I hope he's able to join us later. Badru Tege is, I have worked, well, I've had the privilege of working with Badru, but not directly, but with working with NFT Consult. So I've been in a couple of meetings with Badru. He's founder and director of a business process outsourcing company, NFT Consult, which has offices Africa-wide. He's a board member for the Private Sector Foundation, which is really going to be important for us during this talk, and which has already, this sort of private-public sort of idea has already been spoken about by the minister, by people in the plenary. So this is going to be really good to hear the insights from him. Board member, East African Science and Technology Commission, and yeah, there are many more accolades that I could have put on here, but I just picked out a few to sort of get the gist of where we are. Elvis Mugabe is a software developer, software engineer at Synalytic. When I read his bio, I saw, I think there were 4 or 5 different applications, or sorry, businesses that have been set up, and he's a co-founder of. And I only mention here 3 of them: A23 Labs, MyTransy, and the other one. So he's basically invested in the tech environment. But more importantly, one second. More importantly, there's a lot of focus on working to build sustainable, functional medical distribution systems. So we're in the health sector, and he's really invested in that. And there's lots of other things that he does, but all focused on building tech for the medical field, for the health sector. Derek Konaka works for JSU, which is John Snow International. Chisu, please correct me if I'm wrong, Derek, is a multi-country project that Derek is managing at this point in time, apart from leading JSI's corporate investment in South Africa, and he's also a senior health information systems advisor on several other projects. His focus is on increasing the availability and interoperability of quality health data and information systems, amongst other things. So that's the panel. I will just go back to the main list. I need to see everyone at the moment. So before I start, I sent out some questions, but I don't think we should just sort of follow the questions word for word. But I think the first thing is, every time I say the word interoperability to my colleagues, both techies and not, they sort of, the word sort of is first of all very long, but it's also, it might mean multiple things. So I think I'm going to ask Stephen Senkomago to help us just distill what interoperability means, just generally what it means and what it means in our context, if possible. Stephen.
Thank you, Francis. Obviously, I will start in the weeds. I think the beauty about the panel is we've got people at different levels. I think I'm one of those who are much closer to the weeds with regard to interoperability. So my perspective will be from that side, and I think Badru and Derek.
Stephen, we've lost your sound.
Is that any better?
Definitely, yes, that's all right.
Okay. Sorry about that. How about, is this okay?
That's okay.
Okay, yeah, I think this is a good example of interoperability and sort of my perspective on it. My pricey $150 Samsung earbuds have failed to connect to my machine. So I bought out my trusty $5 wired Skull Candy headphones. So I think that is a good example of interoperability, whereby we have to use systems to talk to each other. Basically, systems have to be able to talk to each other and work together and share data. I think in its simplest, without any jargon, that's how really, because we're in the health sector, we have multiple systems that collect data, manage different aspects of a patient's care record. And so all those systems need to work together, because you cannot have one system to rule them all. So in the simplest is those systems being able to talk to each other, share data with each other, both pushing data to some systems and pulling data so that they can achieve their goal and work in concert. I think I can stop there. That's my perspective. That's how I would look at it.
Francis, I think you're muted.
Yeah, sorry. So yes, I was saying that, yes, that sounds fine. And I think for the group that we are with now, that's okay. And we might get techie later, but we will see to define a few things more deeply. But the other thing that happens every time I say interoperability, or when a project turns up and they say, we want this grant and it's got an interoperability component, everyone, even doctors and other people in the sector, will say to me, why? What's the purpose? What's this word, and what is it? Why? Okay, it means this, but really, why do I need it? I'm a doctor working at Kawala Health Center. Why is it important to me to know what this thing is? This is good for you as techies, but what's the purpose? So in this way, I think I want to ask Derek, because I think he has, we all have different perspectives, but I think from a really high level perspective where you can even go multi-country, but also very low level, sort of, let's say, district to district, your perspective will be really important. So to know why this thing is really important and why it comes up all the time. You know, in the last few years, it's been coming up more and more.
Yeah, thanks, Francis. So, of course, when we're talking about interoperability, the first thing for us when we are doing our work at JSI is asking the question around what is the purpose? Is it, are we trying to exchange data between, are we trying to exchange data about patients? Or are we trying to exchange aggregate data? Or in some cases, are we even looking to do commodity data exchange? And that kind of sets the tone for the discussion. If we're talking to a doctor, for example, and we're trying to motivate for the importance of interoperability, firstly, we don't use the word interoperability with doctors because that scares them away immediately. We talk about exchange of data. We talk about, you know, what is within their context and makes sense for them. Because in some cases, when you're talking to a doctor, maybe they don't even have sort of electronic systems even. And all they're concerned with is, can we just gather the data and can we get people to use it? So our motivation around interoperability, especially when we're speaking at that level, is the idea is we need to get data to be exchanged from one system to another so that we can, number one, We want to limit the duplication of effort, because there's so much effort that's going into collecting data, and simultaneously that effort is being expended across a variety of systems. And if you can actually have a way that you can see what's sitting in another system and you can connect with what's sitting in another system, then there's no need for you to actually then be concerned with collecting that data yourself for your own needs, because you can basically grab that data from somewhere else. The second reason why data exchange would be important at that level would be to get a more holistic view. So one of the things that people struggle with is they want to answer a question, but then they have to look into 16 different systems to get the answer to the question. So the thing we try to motivate, especially around that, is that a big need or a big motivating factor for enabling interoperability is better use of information to get a holistic view and to answer some of these questions without having to gather a variety of data yourself or to look into different systems. And then, you know, if we start talking at the techie level, then we start talking about interoperability layers, then we start talking about the different, then we get into that conversation. But at a very basic level, those are the motivating factors. And most countries that we have worked in are constantly saying that interoperability is a problem. But then if we go through an interoperability readiness assessment, sometimes you find that the interoperability issues are not actually at the technical level, but they're at the people level. And that's a whole other conversation that we can have, right? Where first you need to get people to actually talk to each other and understand each other and understand what they're doing in their different spaces before you can talk about the technical conversation about actually getting their systems to talk to each other. Because I've built my system. I've been running it for 20 years. The government loves it. I love it. I have been enhancing it for a very long time. And then now you're asking me to drop my system and to pick up another system that's been developed by somebody else. No, we need to have a conversation first about the purpose of the data that's been collected in these systems and why it needs to be used. Back to you, Francis.
Wow, there's lots to unpick from that. Yeah. In fact, I think in the first instance, we can talk about the high level, as in maybe not the high level, but as in the programmatic parts of it before we get to techie. Because potentially that's probably, I think that's maybe one of the most important things. And having spoken about the builders, but there's also the policymakers and the people who we need to actually help us or allow us to work with the citizens. And in this way, I want to ask Badru how all these players, especially the ministry, come together, and how to get ministries or the actual governments to actually first of all accept or understand what interoperability means or data exchange means, and also how to help what happens generally when, let's say, there is a government that understands this, but then the private people building things outside, and you know, let's say at Makerere University here, you have lots of kids building lots of different applications. How is the ministry helping, for example, in the Ugandan sense, helping to get this work out there so that I build something in my bedroom in Makerere University, but I know that it's going to work with Stephen's OpenMRS almost immediately. Are these things happening? What are the issues, and how do we get these things to work together?
Thank you for that question. Let me try and simplify the way I approach this conversation. I times when I always want to look at health. Health is just like any other business. The difference is there is somebody, it's about our life, but the rest of the mechanisms behind it are not far different from the needs of a bank. So when you come look at what we have today in the country, is we haven't looked at it from that point of view. Every time we get near health, we create so many complications around it. that even a simple solution sometimes cannot be fixed quickly. I'll share a quick example of last year when the pandemic had just started, and everybody was looking around to how do we help, and I had a conversation with somebody at NITA, I had a conversation with somebody at UCC, and they put me in touch with somebody at the ministry. And we walked in, and obviously at that time, there was a lot of panic, too many things going on. And there was 3 or 4 different companies offering a call center. And the ministry also had a call center. And when I walked into a room, I found a group of people sitting on handsets, taking data down onto a piece of paper. So I very quickly realized this is where I can help. So I met somebody at Mitchell and told him, well, this is what we're going to do for you. And all we did was very simple. We created a backend online database, which enabled any call center agent from anywhere in the country to actually take a call, enter data, but then immediately we then got a lot of interest from the guys at the emergency center, because now they said, great, now I don't want to sift through all this data. I want you to do all of these algorithms so that I can get data like this. Now, something like that, we were able to deliver something in 24 hours, and they were taking calls on the platform in 24 hours. Now, that's a simplicity of technology. The question you talked about is now the complication of it. When we try to complicate what is so simple, and we now bring it into the policy ecosystem, who should be doing that? Where should it be hosted? And interestingly, all of these questions were being asked at the time. But the beauty about it is there was an emergency. Does it work? Yes. I really don't care which server it's sitting on, right? And suddenly we were able to really impact a need in a health ecosystem that a solution was able to be delivered in 24 hours. Now bring it back down to the question that you said, who needs to do what? I think the pandemic has been very, very pivotal in the thinking of policymakers. And I think it was very clear from the Honorable Minister's input. And I've had a number of times in different sessions discuss about how we now change to look at this situation. And we need to figure it from what I call the job to be done. We get kind of locked up so much in how should it be done. And I think somebody's talked about this. And we forget that at the end of the day, we're all patients as well. So the same people who are making it what I call paralysis through analysis are still the same people who need this service when it needs to be done effectively and perfectly. So in Isteco, what we're doing at the Isteco level, it's the same thing in terms of how do we create a smooth process. And the beauty about the Science and Technology Commission, and I think Uganda had an interesting foresight that when the Science and Technology Commission was set up, they actually made sure that we sent private sector. And I think I happened to be one of the few out of about 20 board members, very few private sector, and I had the opportunity to be the first board member of board chairman of the East African Science and Technology Commission. And the question you talked about is really what I found interesting in 80% of the discussions we had, because we had academia, we had institutional science and technology commissions, and then we had a few of us as private sector. And our look is very simple. There's a solution, there's a challenge that needs to be fixed, there's a solution that already exists. We can put it in place quickly. Now we'll go back into the questions and pivotal to what needs to be done. I think what needs to be done is we need to actually disrupt the status quo and focus on the job to be done. That way we'll be able to impact. As I said, we were able to fix a solution within 24 hours. And we had, I think, 5 different call centers all running, and suddenly data was visible from all sorts of different parts of the ministry, which was not visible before. And it was visible in real time. Yeah. So the challenge is still not from the technical point of view. The challenge is still with us now from the the policy and the softer side. If I can just squeeze back to when we talked about the building blocks, for me, I look at what I call the foundational infrastructure, which is the connection, the mobile phone, the fixed line, the lease line. Then you have access to that. Then you need to actually now look at the processing and storage of the services, because again, in the solution we offered, now the question was, is this private data or is it government data? It's an offer on the table. And now suddenly we want to shift it to a government platform. Unfortunately, at the time, there was no government platform able to take that level of call center and the level of processing. So we kept it on our platform. But now that becomes an issue as well. So there are a number of issues that still need to be fixed, but I think we can fix them if we throw away our traditional thinking and look at the job to be done. I'm not sure whether I've kind of touched the question, but let me just stop there. Thank you.
Thank you, Badru. I think that's an amazing answer, because again, there's so much to pick from there, because you have the policy side of things, but you also have the really down and dirty technical work that needs to be done to disrupt and to solve a problem. And I think on that one, I'm going to ask Elvis, because I think, I'm not sure, but on this panel, he's probably built a number of apps. He's solved the most number of problems just by the number of businesses and applications that have been built. So on that sort of side of things, when we talk about the building blocks, Badru has mentioned the foundational infrastructure. Yes, that's really important, and we struggle with that as well here, where you go out into the country and you want to deploy something, but there's no PC, there's no internet. So there's that side of things, but then there's also the other building blocks, the policy, the infrastructure. What other sort of building blocks do you think, or is there a set way that we can do this? As in, is it possible for a country or an ecosystem to decide that this is the way interoperability will work? Is there an academic list of things where this is how interoperability will work, or this is how data exchange should be done from top to bottom? Is that a thing? Is the question.
Yeah. Yeah. I guess to take it from what my experience has been, and then leading to the question, I have, for the vast majority of my entrepreneurial journey, been working with private sector, and then more recently made the transition in the past couple of years to healthcare with the Signalytic, where we have decided to address the infrastructure challenges that exist in the environment. And that has taught me quite a number of lessons that were previously not easy to come by. My background has been in software engineering, and I had a
Hello, have we lost Elvis?
We've lost him.
Yeah, I think it's a relevant, this is a good panel, because we're having technology failures at all different levels. So I think it also helps bring this discussion practically, because we can relate to it's actually happening.
We're living in it.
We're living in it. Yeah.
The foundation infrastructure.
Foundational, yes.
I think this is. I think I'll push this back to you, Stephen, because Stephen Senkomoto, because is there? And I'm really interested in this question, because I am actually working on trying to build applications that work together. But from the top to the bottom, is there a path? Are there specific building blocks, policy all the way down to what kind of API to build, or does it just depend on the problem?
Well, Elvis is back.
Well, yes. let's see what Elvis has to say. Then you can jump in later.
Yes. And the point I was trying to raise is that in trying to solve or in trying to approach the healthcare ecosystem, one of the key observations for us was that in lower level health facilities in the remote areas, they seem to be a grows out of those environments because the infrastructure just does all these innovative ideas attempt to get applied in these environments and inevitably fail because of the lack of infrastructure. So before trying to address this, we had to take a systems view of this, system thinking, where you have to really go through the holistic understanding of the different stakeholders that are participating in these environments. And what we learned was that they are fundamental pillars that exist that would allow for digital systems to and those would include, say, power, connectivity, human element. And our approach to establishing that missing infrastructure. So how we do this is simple. We provide the solar-powered mini servers that are installed in these remote facilities. And through that, we can provide connectivity and that reach the lowest health centers, the lowest level, and even all the way to the community, the VHTs, and those other participants in that entire ecosystem. And so what we've learned is that you can actually build the foundation. Once the foundation has been laid, the infrastructure, it becomes easy for other innovations to participate, and even for the policy to learn from that. I think, as I said earlier, they want, or at least when we came onto the map, we hadn't seen a successful deployment of digital tools within lower level facilities because, again, the same infrastructure gaps existed with power and connectivity, and we've been able to solve that. And we don't do that by working directly with telcos. What we found is that by combining a specific antenna type and also combining blockchain technology, and also solar energy, you can build a solution that can thrive and bring these, again, lower level facilities 1 and 2s that are so far remote back online, right? And so now you could have an hybrid off-grid or on-grid solution work and build it as a platform that anybody, private sector, public sector, could deploy, again, because it's so that has been that's been one of the takeaways we've learned in the healthcare, trying to kind of understand what the context is in these environments, and to know that you would have to respond appropriately to the needs of these environments. Back to you, Francis.
Yes, Francis. To continue from where Elvis stopped, and your question, is there a blueprint? Is there a, I think we have to first understand the landscape, right? One, healthcare is heavily regulated, whichever way you look at it, right? It is heavily regulated by government. And two, it has a direct impact on people's lives. So even their data, I tend to call healthcare data toxic, in that whatever container you put it in, it can't be put with other data. So I keep telling people that people think financial institutions are well protected. Well, they have a lot more money, but it's easy. If your bank balance is 0 today and the whole world knows, it's okay. But if it comes out that you have tuberculosis today, that's a different lasting impact. So healthcare data itself is toxic. And in the environment you have it's a heterogeneous environment, right? It's not, no one solution is going to solve it. No single workflow is going to solve it. So essentially, it is a team effort and not an individual effort. I mean, we are rolling out Uganda EMR. We are probably in about 1,200 public health facilities across the country. And I will tell you that each region is different. Each health facility is different. The dynamics of doctors, nurses, population, power, infrastructure is all different. So by first accepting those tenets, and also the fact that the policy, I mean, there's a lot of talk about policy, but in many ways, the policy is accommodating in a way, right? It's not as bad as we actually think, as a hammer that's brought down to actually lock out innovation and things like that. So in that environment of heterogeneous players who sort of have their own interests and their own needs and their own dynamics, then you add that they have to work together, yet naturally they do not, then you have infrastructure challenges. And also the fact that the frontline health workers are overburdened, they're busy people. Nobody goes to a healthcare facility with time. So time is always against you. When you go to a healthcare facility, you're either sick, it's not at your own pace, like you'd walk into a bank and have, an hour. The mindset, that environment is, I think, where we start from. It's charged by all those different forces. So what is the blueprint? And the blueprint is very easy. I think Badru alluded to it, but he did not, it may not have come out clearly. He said, solve the problem at hand. That's the first one, right? But as you solve it, you need to have, I think while Badru says it casually, like we walked in, talked to the ministry, and then we had the solution in 24 hours. I think I would say Badru would have, and his team probably have been preparing for those 24 hours for the last 5 or 6 years. So that 24 hours itself is, while it's a quick turnaround time, it doesn't show the amount of preparation, networking, stakeholder management, etc., that has been done prior. So if everybody may think they can roll out a solution in 24 hours, but remember there is 5 or 6 years to actually prepare for that 24 hours. So it's sort of like an overnight success, or we deployed this overnight, but there's been a lot of work to prepare it, which also takes us to, I think the word innovation is overrated, overused. It's, it's one of those words when I hear, I get goosebumps because it's just it's a word that's overused. The reality is it's overused. The best innovation is actually pen and paper many times. That's why we default to that, because they solve the problem at hand. So even digital's competition is pen and paper. Obviously, the Makerere student locked in his bedroom coding out an application has not been to a health center with no power that is behind a mountain where there's no network. So every assumption they've made is actually, false. So where does interoperability come in? Is that you have to architecture it in, like Badru will not tell you, like, how were these 6 different call centers able to actually enter the same data? There is some experience that comes to, this is the data, here's the problem we're solving, and we're not building it for just one specific use case, but we're solving a problem across multiple call centers. There are multiple heterogeneous needs. That's the first point, is that the problem has to solve challenges for multiple people. Then later, you actually get into the question that where is this data meant to be? Is it in the ministry? Is it on our own platform? He probably will tell you that, oh, it was segregated from all others because we're planning to move it elsewhere. It's going away. We're just temporary custodians of it and things like that as we figure out this response to an epidemic. So there's a blueprint. Solve the problem, understand the stakeholders. You can be prepared and understand the healthcare landscape. Where is the data? What kind of systems? What kind of solutions? Who else is playing in there? And it's a blueprint almost for everything. But then also remember that you're not alone. So I think that is the blueprint, which is very simple, but very difficult, because Ebola, COVID, everybody's talking about COVID, but nobody's talking about the impacts of COVID on regular antenatal care, regular HIV care, tuberculosis, because there are cascading effects that we don't see. So I think that's the idea is we have to think about it that way with that context in place. I think, Derek, I see your hand up. I don't know if Francis is seeing it. I'll hand over to you.
Yes, go ahead, Derek.
Thanks. Great point, Stephen. I like the idea of solve the problem at hand. Doesn't always work though, but it's a good place to start. I'll give a couple of examples of what I mean. I am based in South Africa. We've worked with the South Africa Department of Health. The challenge or the problem that they wanted to solve was they wanted pregnant mothers to have information available to them on a mobile app. So they found a couple of stakeholders, they put a group together, they got moving, and then they ran into the interoperability issue because they had 3 systems that they wanted to get to talk to each other so that they could collect all this information and make it available. And for them to move ahead and do that, there were 2 limitations. The first was that the standards around interoperability or data exchange standards for the country had not been approved as yet. So this particular problem was one of the catalysts to getting that, getting those standards generally agreed, approved, so that this particular problem that they were trying to solve could be addressed. The second problem was that there actually wasn't a sort of an mHealth strategy for the country. So there were a number of things that needed to be put in place, but because this particular problem was there and there was high-level support for this particular challenge to be solved, then these things were expedited and suddenly, you know, the landscape was now available, or the landscape was now ready for these applications to be ready. And that helped not only for this particular health program, because this was not for all health programs. This was for a specific maternal and child health program that was driving this effort. But then, you know, those kind of building blocks that were put in place in terms of a strategy, agreement on standards were beneficial across the board. And then on the flip side of that, and some of you will probably join a little later when there's a discussion to be had on the interoperability platform that we set up in Burkina Faso. And my colleague Rahim is on the call as well. So we worked with the government to get a central platform to make sure that, you know, human, animal diseases, environmental health was all sort of being tracked in one particular system. And it meant working with 3 ministries to get them to agree that this is how they're going to share their data, to remove the barriers and all of that. But what it needed was essentially a presidential proclamation. So it started from the very top to say that you must, because if that was not there, getting these 3 ministries to sit at the table and kind of have a conversation and agree was going to be a huge challenge. So because it was a presidential proclamation, a presidential working group that was set up, it became much easier to actually have a one health system for the entire country, and then to work with these other ministries that were not at the maturity level of health to have electronic systems within their setup that could be useful. So all that to say that, you know, context, fully agree with you, Stephen, that context is important, identify the problem, help to solve the problem, and then put some building blocks in place. Back to you, Francis.
Wow, thanks, Derek. Really good insights. We have some contributions from the chat room. Zimula Patrick says he loves the paradigm shift from the status quo to job to be done thinking. For the sector currently, a blueprint is required to help guide the transition from a heavily paper-based process to an e-health ecosystem. The policy environment with sector-specific strategies is a good starting point, if not for the guidance, but also for the mapping of available efforts to ensure efficiency at all levels. Actually, this is a good one because there have been efforts by the ministries in Uganda to map all the different applications that are available. I guess to sort of create a baseline so that we can know what applications are out there, and then maybe create these standards around how to get the applications to work together. Maybe I'll just throw this question out there. Actually, before that, I believe there are some hands up. Hold on a second. Oh no, that Badru, is that an old hand or a new hand?
It's a new hand. I wanted to just add a bit on the last two contributions.
Yeah.
Thanks. So what I picked up, and just building on what the conversation has been going, back to the different building blocks in terms of the foundation ICT infrastructure is important. Are we using servers? Are we using handhelds? If we're using handhelds, is it iOS or is it something else? Then when you come to what we call the foundational infrastructure, now this is where now you start looking at things like your data structures, things that Stephen has been talking about, and even Kenneth, in terms of then we start looking at databases, terminologies we're using, how we're referring to people. Now, if we build and agree on the right infrastructure, and then on the infrastructure, then the concept of services that sit on top of these two building blocks, then you can open up, because you now have this structure. You have the infrastructure place. We've agreed on different data sets. Then we can link into the Stevens EMR. Then private sector can come in and be able to even add value to that. Then on the flip side, on the other side, back to what we talked about, the governance, and Stephen really touched on it a lot in terms of what it means. What is the privacy policies? What are the legislative? Then how do you develop that market? How do you finance? Obviously, your finance comes, there's an attraction to finance. We're holding a data set of 40 million people. How do we turn that and create it attractive for the finance side? So for me, I think those as infrastructure, then services sit on top of that. And then parallel to that is the governance structure, which goes all the way down. And I think if we can actually find a way of starting and building on those levels, we'll never get it right at the beginning, but we can build around that. I think that kind of summarizes what I've had from Stephen and Derek. Thank you.
Thank you, Badru. Maybe I'll Elvis, you've got your hand up.
Yeah,
go ahead.
Yeah, just to again build off what the previous speakers have been saying. In our local context, there's been activity on the e-technical working group, the e-health technical working group, to design what you could call a specification to enable this interoperability that we're speaking of now. And I believe the last time this conversation was being held, there was a lot of interest in the FHIR specification that has already been used in different economies. And so I would say that policy-wise, we are inching closer to a point where we'll have these mandates or these regulations in place that encourage data exchange to happen. And also NITA Uganda, the national, pardon me, I will keep it at NITA Uganda, has also been pushing for data privacy and who owns, and also data use, because that's another constant that comes up when we have private players holding what Steve referred to as toxic health data or very critical data. So for what it's worth, I think the FHIR could be the standard that we end up onboarding countrywide.
Wow, thank you. Actually, I was right, Stephen.
Yeah, Francis, thanks. And also, I think that's an interesting, I also want to just throw, I like throwing spanners in the works, right? There is a big concerted effort to build the standards, which is a great move. However, we need smaller, and you will always hear I'm a big proponent of
Hello, sorry,
experiments.
I've had a technical issue on my side. Can you hear me still?
We can.
Excellent.
Yeah.
So I was going to mention something, and around fire and standards, but I will allow Stephen to jump in. Go ahead, Stephen.
Yeah, I think we need the two. I think there is a big push towards having something designed and in play. That is the fire standard, and there's work being done by the eHealth Technical Working Group to do that. However, we also need smaller experiments, smaller experiments to actually provide data into those, as those standards are being built. Sorry, I think I'll repeat myself. What I was saying was, while it's great, we're also having the standards. I think we also need a push towards smaller experiments to help provide evidence and data to actually feed into those standards. Like, what's the experience? I mean, fire as a standard is a 500-page specifications. That's like the guide to database design. It tells you the what, but not the how. So it's also important to have continuous small experiments to actually show that actually, we're using the fire standard and this is how it can be done. And also, just like my experience with my headphones this morning, we assume that fire is by Samsung headphones, but you also need your Skull Candy wired phones. And at times, all you need is a CSV export. Not everything has to be real time, right? So at times, all you need is a CSV export that's imported once a week. So again, going back to solving the problem, at times interoperability may mean something as simple as exporting a CSV file, transporting it, and importing it into another system. So I think we have to look at the two. It's also a spectrum of things, not just fire. I think that's fire on the high end, but down at the low end, we can even have CSV exports and and import into another system, even if it's manual and happens once a month. That's also possible and acceptable. So I think even interoperability, as we talk about it, we need to keep talking about that spectrum of possibilities across multiple systems. Over to you, Francis.
Thank you, Stephen. Wow, there's so much I would love to ask. I could sort of keep going. I know that there's a lot on this panel that we could sort of pick out, but we've got only a few minutes left. I'm going to allow participants on this chat to ask any questions, if any, of the panelists. Any queries? I don't see any hands up for now. Okay, I'll just go ahead and ask one last final question. There is one hand. Patrick Zimula, go ahead.
Thank you so much for the nice moderation. I have loved the conversation, especially having a brand, having the multitude of experience that is on here, having a world where, tech people are weighing in on, policies and, other enterprise architecture that is required, to fit within our context-specific problems. So my question, of course, is very little we have had around the HR capacities, because as one of the building blocks that we require, as you have been alluding to the several other problems that you find, to different places that you go to, someone needs to do something about mapping out, the HR capacities that are out there, because nationally, we're in the realm of thinking that, that there is less capacity, and yet, with the wealth of information that is coming off this platform, that is, one testament to, having misinformation, especially in the mapping that is happening at the center. Then one other thing that, as we break off here is, it's nice that we've talked about the blueprint, but then who does what when you create a blueprint? Because coordination is one other thing that is fading out, not just in interoperability as, one effort that we have in the sector, but then also building into the numerous pesky processes, which are not yet ready before, other building blocks can be laid to effect interoperability. I like that you guys are plugged into the ETWG. And at some point in time, there was talk of an interoperability framework that was supposed to be designed. that really put together the building blocks that, should be worked upon to achieve this. So I like this, and I wish that for our final touches, we would weigh in on, one, mapping the HR capacities that are there, and then two, the issue about effecting coordination for us to be able to achieve the interoperability. Farhan, back to you.
Thank you very much. I'm just going to throw this out to the panel. We could each take a couple of minutes to answer Zimula's questions, because they're really important. The HR capacities, but also what the actual way forward is. What things have been spoken about. The technical working group exists. Everyone is aware in some way, but what is actually happening and how do we go forward from here? Let me start with Derek again.
Yeah, thanks. I'll just speak on the HR one. This is one of the places where I always say people don't like assessments. And we always hear that, we've had many assessments, but it's important to assess things because things change over time. And I don't know if you guys have ever used the Interoperability Readiness Assessment. When I was working at Measure Evaluation, that's one of the toolkits that we produced, and it's with the Health Data Collaborative now as a global good. And in there, one of the elements it looks at three things, right, for interoperability: technology, it looks at human resources, and then it looks at leadership and governance. And within human resources, one of the things it does is actually go through that process of mapping out what skills, what capacity actually exists within the country. It looks at policy, whether there is actually a policy, and it also looks at the capacity development programs that actually exist within that country or within that region. For example, the way that we went about it when we were working with ISTECO, when they conducted their interoperability readiness assessment for that region, they looked at these three things. So there is a framework that can be used. If anyone's interested, I can share a link, but I think it's important to actually go through a process of doing that assessment, gathering the information, having real numbers that we can, an evidence base to work from. Thanks. Back to you, Francis.
Thank you so much. Yes, please share the link either here or by email. And yeah, I will make sure I disseminate it to everyone else. So next, maybe we could hear from, on the same two questions, Badru.
Thank you. The HR function in terms of the question goes back to the foundational infrastructure. Do we have the ICT professionals and technical support training within the health ecosystem? I think for Uganda, for where we are, we have the technical knowledge in terms of ability. Do we have developers who can work in that space? I think the answer is yes. And really that is usually demand driven. The challenge is traditionally and I think I picked it up in one of the earlier sessions, we've always looked at health as a space that is left for government and our donor partners. And we've not really seen a lot of movement into health, and we're just starting to see that movement into the health space. But and I think one of the Elvis clearly said that he shifted from a different space to another space. I don't think we have a challenge or that big a challenge. What we might have is probably the ability to do the analysis in terms of how do you translate a health need into a technical need. So that might be a challenge. Then Derek mentioned something interesting in terms of the different readiness areas. And he talked about the leadership and governance. The challenge that we might have there is usually the people you're presenting to these completely new approaches are the very traditional thinkers, and they're the decision makers. And getting them to adapt from 20 pages or 20 folders on their desk to looking at a spreadsheet or a dashboard might be a bit harder. So that might be where we might have a bigger challenge, but I don't think we have a bigger challenge on the knowledge side of it. I'm not sure what Stephen will say, but that's what I'm thinking. Thank you.
Stephen, you're really invested in training and helping people in OpenMRS and basically skills transfer. I wonder what your impressions are on the HR side, but also on the way forward, really.
Well, again, that's why I keep talking about experiments, right? Those experiments are what we used to learn. Obviously, my focus is not just, I mean, even you've heard me, I think we've had discussions where you're saying, I'm looking for an OpenMRS developer. And I tell you, yeah, it's just a tool. You need a good Java developer whom you can bring along on the journey to actually pick up the OpenMRS aspect. So like Badru said, the key challenge is demand. But I think even the approaches, I keep telling everybody, big bang doesn't work, right? You need a few, you need a few experiments that gradually gain momentum. Then after a while, it's saying that, how did we do it any other way? I think our bigger problem is also in approach, in that we go with to a traditional thinker. It is very difficult to convince them without some sort of evidence, without some sort of win, without some sort of roadmap and path. I mean, all of us are entrenched in our very own, how do you call it? I would call them biases based on experience, education, and exposure. So I think changing that requires us, one, to have the big picture goals, the paperwork that's needed for governance, which is the standards and things like that. But we also need some small experiments to get them to see the light, because essentially you're taking all these stakeholders on a journey. The interesting thing about this journey is in 10 years' time, what we think is the interoperability problem will have changed. So essentially, we also, it's a journey that never ends, because the moment you solve one problem, then another one becomes evident, because now you have matured. And before, we're not talking about infrastructure, we're talking about data security, governance, the quality. I mean, it keeps evolving over time. So I think even us, we're in our mindset, we also have to have the fact that, one, it's a journey, but two, that keeps evolving. So we need some small wins, experience, losses that are, how do you call it, that are contained, so that we keep bringing everybody along on this journey, so that we get a lot more buy-in along the way from developers, practitioners, even the academia. Everybody seems to leave out academia, but it's important, because academia is generating the next crop of decision makers in 5 to 10 years. So I think it's bringing everybody along this journey of discovering, how things work. And it's not a healthcare problem only, because your national ID fingerprint cannot be used for your NSSF, cannot be used in your bank. So it's it's across multiple sectors.
Yes. I think I'll give Elvis a chance to comment, and then we will all just sort of, I'll ask the panelists to just make one last comment on the session, just generally what they feel they've, basically what a final comment just on the subject and what they feel about the subject currently, and how it fits into what we've been talking, or what the minister spoke about in the morning, and rest of it. So over to you, Elvis, and then we'll just go around one more time, and then we'll close this.
Okay. Yeah, I think Patrick raises a good question on the human resource aspect and how we should address that. I think from our learning here, we've identified, or rather observed, that the end user as well, who in this case could be a village worker, or a store manager, or anybody, health worker, basically, they really have to have a motivation to adopt and have the willingness to use the ICT or a system they've been handed, or even tool, whether it's digital or analog. And if we can think of building incentives, and these incentives could initially be, it could be extrinsic, initially, just to get them to adopt and overcome biases that they may have, where they may feel like, maybe they would have their job replaced, or this is burdensome for them, and work through that slowly until we get to a point where they are intrinsically motivated to adopt the ICT tools that we require really to have this data available upstream and downstream. And I think that being able to explain and show these end users the impact they have in diligently, filing a report of a triage incident or medicines they've issued, and showing them how that would benefit their community or how that is impactful down the line could be what we also need to lean in against to support these people and get them interested in using the tools. I honestly think that these tools exist, and some people believe that at least in the HMIS or in the health information system space, that we have crowded solutions, but we don't have enough usage, and the user adoption trickles away after the initial implementation stages. And so there's a lot of thinking we need to do around that, where we go with the user-centered design or the design thinking to make sure that the solutions are actually addressing needs, and then work our way to that future where people would, or these end users would, a lot more easily use the tools we provide. So that would be how I would address the EHR. And of course, you've done a fantastic job of indicating that on the higher level, the developer, there's a market for that and it's demand driven.
Yeah. Thank you, Elvis. So yeah, because of time, I think I'm going to allow just a very short period of time for our panelists to comment or final thoughts, basically. I'll start with Derek again.
Thank you, Francis. Interoperability is a technical, organizational, behavioral intervention. The technical is the easiest part. Organizational, a little bit more tricky, but you can actually get some organizational change, introduce some systems, get some structure. The toughest is a change in behavior from the top all the way to the bottom. And if we appreciate the importance of behavior and spend more of our time trying to change that behavior by changing the system, then we'll achieve interoperability. Thanks.
Yes, Stephen.
Yeah, I think it has been said very well. I think the idea is, as behavioral change, 80% of our challenges, obviously, everybody says tech is hard, but tech is the easy part. The behavioral change, because it's not a one-off, is important. And even our old timers, whom we say are difficult to convince and so on, at times, probably we need to step back and listen to their problems, to their pain points. Once we understand the aspects that they're interested in, it's actually easy to grab their attention and actually get buy-in from them, because we are solving the challenges they are interested in and are important to them, rather than the ones that we think are. So at the different levels, from the commissioners, district level, health facility workers, and so on. I think the idea is to mold the solutions and approaches in such a way that we're solving problems for each of those people, so that they can, they can actually adopt whatever systems and solutions are in place. So behavior change is the most important aspect to actually make this sustainable over the long term.
Awesome, thank you, Stephen. Elvis?
Yeah, I would agree with the initial, keynote address by the minister, who said that, in her opinion, COVID had been a blessing in disguise. I think that the innovation engine has gained a lot more momentum throughout this period. And now we have a lot of stakeholders that maybe were sleeping on the job previously, being asked to make these things happen. And I think that's great. I think we will come out of this better, and there'll be a net positive effect here as far as health system interoperability goes. So I'm optimistic. I've also heard what's happening on the technical working group, and it feels like the the wheels are turning, not as fast as we would wish as innovators, but nonetheless they are turning, and that's and I think that that's something that we could look forward to.
Wow, I'm really glad that there is that feeling of optimism, that you can express that feeling of optimism, because from my point of view, I see lots of applications, lots of different things going on, and it's not easy to see how these bits and pieces will fit together. But from this chat, yes, I have a sense of optimism, and I hope we sort of keep this going. Lastly, Badru, your final thoughts.
Thank you. Thank you. I think interoperability in the long term will not be an issue thanks to AI. As we start flipping that side, we'll build systems that will be able to read and interconnect. But for now, I think for me is focused on the job to be done, not the technology. Build a data structure that can be reused. Think open standards, allow many in and refine later. And that to me will create an ecosystem very quickly that has a healthy e-health ecosystem. Thank you.
Okay. Wow, I cannot tell you how privileged I feel to have been on this panel. And I'm really grateful that you took your time out to come and speak with us, give us your experiences. And I also hope that, first of all, you will stay and join in with the other, in the other conversations today and tomorrow, but also that we will stay in touch, because we are all sort of trying to do similar things, as in, or basically the focus is, to solve problems for the person on the ground, health problems. So I hope that we will be in touch a bit more to actually get our different sort of bits sort of working together, because we are all at this point, to be honest, working on different things. So I'm really grateful. Thank you so much. And also thank you to the participants for joining in. And have a nice day, and we'll see you on the other side. Thank you so much. And goodbye.